Clinicians face a massive volume of criteria during a pediatric motor exam. The sheer number of required checks can lead to immediate cognitive overload. This exam functions as a structured topographical map of the central and peripheral nervous systems, moving beyond a simple checklist to provide precise anatomical data. The ABCDP-GST mnemonic provides the necessary clinical framework to ensure every component of the motor system is evaluated. This sequence tracks abnormal movement, bulk, coordination, deep reflexes, power, gait, superficial reflex, and tone. The exam follows a strict chronological order, beginning with hands-off visual observation before transitioning into dynamic, hands-on physical manipulation. Following this systematic approach enables the clinician to isolate anatomical lesions with precision. The first stage of the exam is entirely observational. You assess the patient's resting state from a distance without physical contact. Severe resting postures serve as a direct broadcast of the location of brain or nerve damage. In decerebrate posture, all four limbs are extended with internal rotation at the joints. This physical presentation indicates a neurological lesion located strictly below the midbrain's red nucleus. Compare this to decorticate posture, where the upper extremities are flexed while the lower extremities remain extended. This flexion places the lesion at a location above the red nucleus. Visual cues also identify peripheral nervous system issues, such as a frog-like state, where the child's hips and knees are abducted and flexed. This specific posture points to lower motor neuron pathologies, including spinal muscular atrophy or polio. Opisthotonus is a critical red flag posture characterized by severe spastic contraction of the neck, trunk, and extensors. Recognizing these severe resting states allows for immediate clinical action based on the indicated location of neurological distress. The first hands-on phase involves assessing muscle bulk to identify asymmetry, atrophy, or hypertrophy. Approximating limb mass by eye is insufficient for a clinical diagnosis. Accuracy requires a three-step protocol. First, identify identical bony landmarks, like the tibial tuberosity. Second, measure exactly 3 fingers below that point. And third, take a precise circumference measurement. This geometric consistency ensures a reliable comparison between both sides of the body. These measurements help distinguish between reversible disuse atrophy from immobilization and neurogenic atrophy caused by lower motor neuron lesions. You may also observe pseudohypertrophy, which presents as an enlarged calf or tongue muscle. Identifying the specific type of abnormal muscle bulk helps narrow the pathology to conditions like Duchenne muscular dystrophy. During the dynamic phase, you passively move the patient's joints to test the natural resistance of the muscle tone. The specific quality of this resistance indicates which brain tract is affected. Spasticity is defined by speed-dependent resistance. The faster the limb is moved, the more it resists, often resulting in a sudden clasp knife spike. This finding points to a lesion in the pyramidal tract, which is responsible for voluntary movement. In contrast, rigidity feels like bending a lead pipe or turning a cogwheel, where the resistance remains constant regardless of movement speed. Constant resistance isolates the damage to the extrapyramidal tract, which governs background motor control. A total lack of resistance is termed hypotonia. This presents as flabby muscles and increased joint flexibility, often called a floppy presentation. These tactile findings serve as biomechanical tests that map physical sensation to functional neuroanatomy. Infants cannot follow verbal instructions, so their assessment relies entirely on quantitative measurements. Clinicians measure specific joint flexibility and extensibility angles to determine the precise state of an infant's muscle tone. Normal ranges are strictly defined: 40 to 80 degrees for the adductor angle, 90 to 120 degrees for the popliteal angle, and 60 to 70 degrees for dorsiflexion. Angles that exceed these ranges suggest hypotonia, while narrower angles indicate hypertonia. In infant diagnostics, the most significant metric is the symmetry of the popliteal angle. An asymmetry greater than 20 degrees between the left and right legs serves as a clear indicator of asymmetrical motor pathway damage. Physical maneuvers confirm these findings. The heel-to-ear test measures how far the foot moves toward the head without significant pelvic lift. The scarf sign involves pulling the arm across the chest. In a healthy infant, the elbow resists crossing the midline. Finally, the traction response, pulling the infant into a sitting position, reveals hypotonia through excessive head lag. These quantifiable metrics provide an objective basis for the infant motor diagnosis. We can see how these deductions function in practice by evaluating a specific clinical scenario. Consider an infant presenting with an adductor angle of 30 degrees and distinct clasp knife resistance during passive joint manipulation. Because 30 degrees is narrower than the standard 40 to 80 degree range, we have physical proof of hypertonia. The speed-dependent clasp knife sensation further identifies the specific presence of spasticity. Combining this quantitative and tactile evidence locates the lesion within the pyramidal tract. This systematic progression through the motor exam maps physical findings directly to the intricate internal wiring of the human